now invite Dr.S.C.Govind, Senior Consultant and Head Ecolabs at Narayana Hridayalaya in Bangalore. Dr. Govind joins us this afternoon to deliberate for the next 12 minutes on echo in pulmonary embolism.
Good afternoon to all of you. Coming to the last topic, echo and emergencies. This is about pulmonary thromboembolism. We all know that it is a potentially fatal condition, and it is one of the few conditions where we tend to overdiagnose or underdiagnose, and when we underdiagnose, either in the form of not diagnosing or a delayed diagnosis, the consequences can be quite lethal. So it's important that we have a timely diagnosis. The causes for the pulmonary thromboembolism usually arising as a clot from the deep veins or from the pelvis. It can also be in the form of a tumor or a fat or air, but most commonly a thrombus. That is what we'd be looking for. And it's typically one of those lesions which is something like a stop and obstruct sort of lesion. It obstructs, and depending on the site of where the obstruction is and how severe the obstruction is, it has a lot of consequences in the form of the pulmonary vasculature and the RV, and that's where the problem starts. Now, the difficulty in diagnosing is always been because of its varied clinical presentation. It has a lot of non-specific symptoms, but more or less the vast majority have one of four symptoms. They can be dyspnea, they can be chest pain, and hemoptysis, and they can come in the form of a central nervous presentation like a syncope, fainting, and even seizures have been reported. So it is important that to have a timely diagnosis, that we need to have an integrated diagnostic approach. What are the ways, what are the tools that are available to us? Obviously, the clinical presentation assessment is the first line, and then we have the D-dimer, and then we have imaging. We have the CT pulmonary angio, which is the one which occurs right at the top, and then the perfusion scanning, and then the supportive test of the lower limb ultrasound and echocardiography. Of course, pulmonary angio is the alternative, which is termed as the gold standard, but it's more of an alternative. The other tests which are of supportive nature can be the chest X-ray, ECG, BNP, and troponin. We start off with echo, and what can echo provide us? It can provide us information in the form of transthoracic as well as TE. In transthoracic, we have to look at structural measurements of the chambers. We need to assess the RV function. We have to assess the presence and the severity of pulmonary artery hypertension, and whether the thrombus is seen or not. In terms of measurement, we need to look at the RV size, the RA size, and then there's been a lot of data on the RV-LV size ratio, and then also on the RV-LV area ratio, and also the presence of RVH, which implies that it has been there for a longer period. The RV sizing, one can use various methods. I've just shown one here, and you can also look at the RA sizing also to look whether it is dilated or not. And these are the two ratios which have a lot of attention. And then looking at the RV and LV size end diastolic ratio, if it is more than 1, then it implies that there is a possibility of pulmonary thromboembolism. And also to look at the area as such of both the chambers, and if that ratio is more than 0.6, that again implies that possibility of pulmonary thromboembolism. And one needs to look at the RVH also. One can use various views. This I'm showing the Patterson long axis, and if it is more than 5 millimeters, we know that there is right ventricular hypertrophy, and this is in favor that it has been there much longer. RV function itself can be assessed in the forms of TAPSE. These are the traditional methods. You have the fractional area change, and then you have the RV myocardial performance index, and you have the newer applications of tissue Doppler and speckle echo. The visual part it's very important to find out whether there is any free wall hyperkinesis. There has been a lot of articles on the McConnell sign, which has had its rise and then again its fall because of its questionable sensitiveness. And also there have been some articles on the reverse McConnell.